Hello everyone, this is Marwan from the Daily Pharma channel. I am happy to have you here as we continue with the next part of the Pharmacology Made Easy series, focusing on pharmacokinetics, specifically metabolism and excretion. In the previous lecture, I explained that the pharmacokinetic properties are divided into four key processes: absorption, distribution, metabolism, and excretion. We covered absorption and distribution in detail, along with the factors influencing these two processes. In this lecture, we will focus on the remaining two properties, metabolism and excretion. After a drug has been distributed and has acted at its site of action, it returns to systemic circulation. As mentioned before, for drugs to be absorbed and distributed, they must be lipophilic in nature. However, this presents a challenge because lipophilic drugs cannot be easily excreted from the body, which may lead to accumulation, toxicity, and undesirable side effects. This is where the process of metabolism comes into play. Metabolism, or biotransformation, occurs primarily in the liver and other tissues as well, and converts the drug from a lipophilic form into a hydrophilic one, making it easier for the body to excrete drugs. Lipid-soluble agents are metabolized into more polar hydrophilic substances in the liver via two general sets of reactions called phase 1 and phase 2. Phase 1 reactions convert lipophilic drugs into more polar molecules by introducing or unmasking polar functional groups, such as hydroxyl and amino groups. These reactions typically involve oxidation, reduction, or hydrolysis, and are catalyzed by a group of enzymes known as the cytochrome P450 system. Many drug-drug interactions are related to these enzymes, and we will discuss this topic in more detail later. If a metabolite from phase 1 is sufficiently polar, it can be excreted by the kidneys. A metabolite is the product of the metabolism of the parent drug. However, many phase 1 metabolites are still too lipophilic to be excreted effectively. Therefore, phase 2 reactions, which involve conjugation with endogenous substrates such as glucuronic acid, sulfuric acid, acetic acid, or amino acids, take place. These conjugation reactions produce polar, usually more water-soluble compounds that are often therapeutically inactive and easier for the body to excrete. The liver is the most significant organ for drug metabolism because it contains the majority of enzymes necessary to convert drugs from lipophilic to hydrophilic metabolites. A few moments ago, I mentioned that many drug-drug interactions are related to the metabolism process, specifically involving cytochrome P450 enzymes. How does this occur? When two drugs are taken together, one may increase the activity of cytochrome P450 enzymes, which accelerates the metabolism of the second drug. As a result, the second drug is converted into a hydrophilic form before reaching its site of action, reducing its effectiveness and preventing it from providing the desired therapeutic benefits. Conversely, when two drugs are taken together, one may decrease the activity of cytochrome P450 enzymes, slowing the metabolism of the second drug. This can cause the second drug to accumulate in the body, potentially leading to toxicity and adverse effects. There are drugs known as cytochrome P450 inhibitors, which slow down the metabolism of other drugs, leading to their accumulation in the body and increasing the risk of toxicity and adverse effects. Examples of such drugs include erythromycin, ketoconazole, omeprazole, and carvedilol. On the other hand, cytochrome P450 inducers accelerate the metabolism of other drugs, reducing their therapeutic effectiveness. Examples of cytochrome P450 inducers include phenobarbital, rifampin, carbamazepine, and phenytoin. For example, consider apixaban, an anticoagulant that's metabolized by cytochrome P3A4 if taken together with ketoconazole, a cytochrome P3A4 inhibitor. Ketoconazole will reduce the activity of cytochrome P3A4, causing apixaban to accumulate in the body. This accumulation increases the risk of adverse effects, with bleeding being the most common. Another example is atorvastatin, an antihyperlipidemic drug metabolized by cytochrome P3A4. If taken together with carbamazepine, a cytochrome P3A4 inducer, carbamazepine increases the activity of cytochrome P3A4, leading to the rapid metabolism and clearance of atorvastatin. As a result, atorvastatin's lipid-lowering effects are decreased. While drug interactions are often associated with cytochrome P450 enzymes, another important mechanism for drug-drug interactions involves P-glycoprotein. In the previous lecture, I explained that P-glycoprotein is a transporter protein that pumps drugs out of the cell. Some drugs, known as P-glycoprotein inducers, increase the activity of P-glycoprotein, leading to an enhanced expulsion of drugs from the cells and thereby reducing their effectiveness. Examples of P-glycoprotein inducers include dexamethasone, carbamazepine, and clotrimazole. On the other hand, some drugs act as P-glycoprotein inhibitors, which decrease the activity of P-glycoprotein. This reduction in pumping drugs out of the cell can increase the risk of adverse effects and toxicity. Examples of P-glycoprotein glycoprotein inhibitors include amiodarone, verapamil, and ceftriaxone. After discussing metabolism, the next pharmacokinetic property to consider is excretion. Excretion is the process by which a drug and its metabolites are removed from the body. This elimination occurs through various routes, including urine, feces, saliva, milk, tears, sweat, and other bodily discharges. Drugs are mainly excreted in kidneys. Renal elimination of drugs involves three physiological processes. They are glomerular filtration, proximal tubular secretion, and distal tubular reabsorption. Glomerular filtration is the process by which drugs enter the kidneys through the renal arteries and flow into the nephrons, the functional cells of the kidney. Free drugs pass through the capillary slits into the Bowman space as a part of the glomerular filtrate, eventually becoming part of the urine. However, protein-bound drugs cannot be filtered through this process. Instead, they are transported to the urine via a second mechanism called proximal tubular secretion. Proximal tubular secretion is the process by which protein-bound drugs are actively transported from the blood into the urine. As drug moves toward the distal convoluted tubule, its concentration increases and exceeds that of the perivascular space. The drug, if uncharged, may diffuse out of the nephroglutinin back into the systemic circulation in a process called distal convoluted reabsorption. While if a drug is sufficiently charged and hydrophilic, it may be excreted through a third mechanism known as distal tubular secretion. This process involves the active transport of such drugs from the blood into the urine within the distal convoluted tubule. Finally, we have covered the pharmacokinetic processes that occur after drug administration. In the next lecture, I will discuss how these pharmacokinetic processes, absorption, distribution, metabolism, and excretion, affect the onset of action, half-life, dosing frequency, and steady-state concentration of drugs. If you enjoyed and found this lecture helpful, please subscribe to the Daily Pharma channel and click the bell icon to be notified about the upcoming lectures. Thank you for watching.